Morning to all of you. I would again like to thank all of you for attending our session. Thank all our speakers and Dr. Lalit Verma also, who also joined us. So I'll be speaking on the management of bleeding during diabetic vitrectomy. I think diabetic vitrectomies are one of the most, can become one of the most difficult cases for a VR surgeon, especially during early times. And if there is a bleeding, then it becomes absolutely difficult to proceed. So it's like a war. You have to prevent bleeding and you have to also prevent the formation of retinal breaks. So I always think that I always instruct that the hemorrhage have to stop first before proceeding for the surgery. If you allow the blood to spread and the bleeding will continue, then you can't proceed with the surgery and it might become a problem. So with the advancement in the technology, the bleeding risk has greatly reduced, but still it is still there. Now we have got smaller gauge vitrectomies, better viewing systems. We even got chandelier system, but still vitrectomy is a major complication in diabetic vitrectomy. So I'll be approaching from a step-by-step approach. So this is like a simple case. The blood is there. There are mild bleeders which are there. Most of the dissection now, I think we do with a cutter only, with the 25 gauge cutter or 27 gauge cutter. You can go very close to the retina. You can sit on the retina and do most of the dissection. So this is a case in which there were mild bleeders were there, and just with the help of a endo laser or with the help of a diathermy, you can just close these bleeders and you can proceed with the surgery. So this is not much of a problem. So I'm just just diathermizing these bleeders. You can also use laser photocoagulation to close these bleeders, and there's not much bleeding and there are no breaks. So in the end you just do a pan-retinal photocoagulation and there is no need of any tamponading agent in such a case. So this is the first thing. If there is a mild bleed, you can just cauterize it, and a bimanual approach is very helpful in such cases. You can aspirate with one end and with the other end you can just diathermize those bleeders, or you can proceed with the laser also. So I always prefer to cut the hyaloid first in the periphery and then come to the posterior pole. If you come straight away at the posterior pole, sometimes there is chances that there is a very risk of a very severe hemorrhage because of the fibrovascular proliferation of the disc. So what to do next if the bleeding is not getting controlled or not able to localize the bleeders? And you just raise the IOP. Now we have got excellent machines. You just have to press a button and the IOP is raised. But the important point is here that you have to monitor the time. The disc, the perfusion of the disc in such cases is usually compromised. So you don't have to keep the IOP high for a very long time, not even more than probably 1 or 2 minutes. It's very important to bring the IOP down and look for the bleeding again. We have to monitor arterial pulsations. If there is any presence of any arterial pulsations, then you can't raise the IOP. So this is very important. This is one of the reasons probably you have done an excellent surgery and you have got a PL negative eye the next day. So still, if you're not able to control the bleeding, so what to do next even after raising the IOP? So this is a case in which I did outside in approach. As I said, I'm first dissecting the peripheral vitreous. Now you can see there is a dense fibrovascular proliferation which is present at the macula and at the optic disc. So while doing the dissection, there is presence of severe hemorrhage which was present here and I was not able to control it. So I'm doing again most of the dissection with the help of cutter only. So this is a case in which I'm doing a diathermy and just raising the bottle. So I'll just discuss the next step. So again, in this case, most of the dissection is done with the help of a cutter only. You can see you can dissect most of these membranes with help of these cutters, go very close. So again, this is a case in which the bleeding was controlled with the help of raising the bottle, or you can, even if the bleeder is visible, you can just apply gentle pressure with the help of your cutter only or with a back flush directly onto the bleeding vessel, and in most of the cases the bleeding will stop. So in this case, in most of the diabetic cases, we also do ILM peeling, and this is again followed by a pan-retinal photocoagulation, and luckily no break was created, so no need of any tamponading agent also. So this is another instrument which is developed. I've not used it, but I think it is a very interesting instrument. So this is an end aspirating endolaser probe. So with this, while doing a laser, you can continue to remove the blood surfaces and you can continue with the PRP. It can also be used to treat the bleeders by the endophotocoagulation. I've not used it, but I found it in the literature, so just thought to mention it. So what to do next? If the bleeding is still there, you plug all the ports. It is always better to use valved cannulas. We have to wait for 2 to 5 minutes. In most of the cases, the bleeding will stop. You can clear most of the hemorrhages and proceed with the surgery. So important here is to wait for about 2 to 5 minutes. So what to do next if the bleeding is still not getting controlled and you can't see the bleeders? The next step is using PFCL. I use PFCL quite liberally if the bleeding is not getting managed. So this is another video. Yeah. So in this, there is a thick fibrovascular front which is present in the disc, and the bleeding was not getting controlled. So I could not remove the membrane. So PFCLs, these are heavy liquids. They tamponade the retina. They close the bleeders. They even act as a third hand. You can proceed with most of the surgery. You can do some membrane peeling. The important thing in diabetes is you should never pull a membrane straight up. It should be tangential, or you should dissect it. So in this case, since the bleeding was not stopped and I was not able to do most of the dissection, I injected a bubble of PFCL, and with the help of PFCL, now under PFCL, I was able to remove this membrane. You can see this membrane has come out gently, but again, you have to be very careful. There is a risk of creating breaks, and in diabetic cases, it is inevitable sometimes, and sometimes you create a break. But again, in this patient, the break was not created. So if a clot is formed, what to do? If a small clot is formed, my advice is never try to remove it. But however, if a large clot is there, probably you should try to remove it. If a rebleeding occurs, then it's much worse. So in this video, there was a clot which was present. A pre-retinal clot usually will not cause much problem. There was a clot which was present and it was bleeding persistently. So I decided to remove the clot. So this is just to highlight that sometimes if the bleeding is stopped and the clot is not large, then it's better to leave it. So I proceeded with the pan-retinal photocoagulation, gave the PFCL some time to pressure tamponade the bleeders. So after that, I removed this clot. So you can see with the help of a back flush, I removed most of the clot. But unfortunately, and I think it will happen in most of the cases, at the end of the surgery, the clot again reappeared at the posterior pole, but then I decided to leave it because it is a small pre-retinal clot which is present, and it will eventually go off. So although I have successfully removed the clot and I'm quite happy here, but once I did the air fluid exchange in the end, you can see the clot is again formed. At this stage, I decided to leave this blood, and definitely this amount of blood will not cause much problem. So it's always better not to run after clots, because if a rebleed occurs or if the bleeder opens, then it will lead to severe worsening. So this was another diabetic case. This was a tabletop detachment, an old TRD. You can see there is a thick fibrovascular proliferation. So I injected again under PFCL, again tangential traction. It's risky, but again lucky for the patient and for myself. Most of the membrane and the traction was removed under PFCL, and then dissection was done with the help of a cutter. So most of the detachment in this case was present in the center, in the macula. The periphery was attached. So after successfully removing this whole of this fibrovascular proliferation from the retina, I did a peripheral photocoagulation, and again, since no break was created, these TRDs usually take time to settle. So you can see that the peripheral retina is settled. However, the detachment is here. So I just did a photocoagulation in the attached retina and the periphery, and left this central part. And it took time to settle, but eventually it will settle. And if you have not created a break, one important thing while using PFCL is that if there is a traction and you have created a break, then the PFCL will go subretinal. So you have to avoid creating breaks, and if there is a break in the area of a traction, then you should avoid using PFCL, or you have to be very careful, because if a traction is not released, then the PFCL will go subretinal. So this is another case. This was a one-eyed patient. This patient, the one eye he had lost, this was his other eye. You can see the patient has got a thick fibrovascular proliferation involving whole of the disc and the macula. This was a huge challenge for me, but the patient we didn't had any other option apart from operating it. So I've cleared all of the peripheral vitreous. I've done a pan-retinal photocoagulation, and now I am dealing with this central front. So there is a continuous bleeder which is happening despite everything. So I injected a PFCL bubble, and I'm tilting the bubble, continuing with my dissection. In this case, I'm using a scissors because I'm directly over the fovea, and I wanted to be very, very careful because this was his only eye. So sometimes you can just tease these membranes, and you can find a plane, and then you can just go beneath the plane and continue with your dissection. So the PFCL the eye was rotated to tamponade the bleeder, and then it was rotated, and the dissection was continued further. So in this case, after releasing all the traction, I did not remove all of the fronts which are attached. My aim was to just relieve all the tractions, do the minimum risk so that the patient has got some vision later, some mobile vision later in his life. So you can see most of the membrane has been, most of the traction was removed from the macular area, and a dissection has been done. So this was the fundus picture at 1 week. You can see there are some fibrous fronts there, but the fovea is clear. This is the picture at 1 month. This is the montage picture at 1 month. This patient gained a vision of 6/12 and was reading a newspaper in my OPD, and that is one of the most gratifying things. So still, if the bleeder is not localized despite all your efforts and still there is a continuous bleeding, you should not operate in the blind. It's always better to close the surgery, do not create any breaks, and replan the surgery after a week. But there is also one more thing which I have done in 3 or 4 cases. There were some publications of leaving the PFCL inside the eye, which has been done for GRTs. So what you can do if there is a persistent bleeding, you can use PFCL as the tamponading agent, but you have to be very careful. You have to remove the PFCL after 3 to 5 days and replace it with either gas or silicone oil, because the PFCL could be toxic to the retina. It can lead to retinal toxicity and to damage of the retina. So this is another option, and I've done it in 3 to 4 cases, and it is very effective. It will definitely stop all the bleeders. But the important thing is you have to be very careful for the inflammation and the retinal toxicity, the pressure, the mechanical pressure toxicity. So you have to remove the PFCL. So again, the prevention is best before operating a diabetic case. You have to take control of the diabetic status, the hypertensive status. You have to stop all anticoagulants, antiplatelet agents. Anticoagulant use are associated with a higher risk without any serious consequences, but they increase the duration of the surgery and may also increase the risk of post-operative hemorrhages. So diabetic cases are one of the cases in which you'd like to stop all these antiplatelet and anticoagulants. The hypertension, the sugar, and should be under control. Even the hemoglobin levels should be under control. And a prolonged surgery always increases the risk of intraoperative and post-operative bleeding. So this is one thing which has really revolutionized the treatment of the management of diabetic TRDs. I prefer to give in almost all of my cases 3 to 5 days before. I prefer to operate at 3 days. So they have really reduced the risk of bleeding. They have made the surgery much more safer and easier, but still there will be some bleeding in cases in which there are severe hemorrhages. So putting it all together, just to conclude, I think everybody has its own technique, but these are some useful tricks. It's always better to use valved cannulas. Chandelier systems are excellent. You can have a bimanual approach. You can aspirate with one hand and you can do the laser with the other hand. It's always better to cut the hyaloid from the periphery and then come to the center. You can use active aspiration from one hand if you're using bimanual surgery, and you can do the coagulation with a laser or a diathermy. It's always better to use pre-operative anti-VEGF agents. We should not pull a fibrovascular proliferation. It's always better to do it a tangential traction, and that too under a PFCL if possible. A difficult to control hemorrhage at the disc will prevent the further surgery, and probably you'll have to inject silicone oil also, which increases the risk of post-operative high IOP. So use of PFCL, as I have highlighted in my presentation, it gives a clear media, it pressure tamponades the bleeders. It also gives a better laser reaction. It gives us time so that you can continue with the PRP. And it's very important to if you have left PFCL at the end of the surgery because of a continuous bleeding, it's very important to reoperate after 3 to 5 days and remove the blood. So thank you, all of you. Yeah.
3 to 5 days. I've seen that the PFCL goes subretinal also sometimes through a small break. So is there a way to remove it?
See, so definitely there is a way. It depends where the PFCL bubble is. So first of all, as I said, if there is a traction and if there is a break. So the most important thing, you have to avoid the formation of a break. If you have formed a break and there is traction, then only the PFCL will go subretinal. If there is no traction, the PFCL will not go. So it depends on the location of the PFCL where it is. If it is extramacular, probably with a simple backflush, you can remove it. Now again, if the PFCL bubble is at the macula and it is usually stuck, you can't create a retinotomy. So the best way is, which has been described, I have not done it. It is to create a retinal detachment. You have to create a retinal detachment by injecting fluid above the macula, and then probably that will loosen the PFCL bubble, and then you have to aspirate it from there. Or again, then you have to probably create a larger retinectomy, go behind the retina and remove the PFCL bubble. But you can't leave a large PFCL bubble at the submacular area. It will eventually damage the RP cells there. So the important thing is to prevent it, because having a subretinal PFCL at the macula is a very, and usually these bubbles are very, very small. You can see them on OCT. So you have to create a small retinal detachment with the help of a 41 gauge, and you have to displace it and then absorb it from there.
No, the issue was that intra-op you do not see any subretinal PFCL. You don't even identify a break, but post-op you see that PFCL is behind.
That's what I'm saying, and that also you will identify probably after 2 to 3 weeks.
Yeah.
So another important thing is the vision of the patient. how bad is the vision. If the vision is probably 6 by 18 or better, I would
Then
probably
leave it.
not do anything. I will leave it. If the vision is worse than probably 660, then probably I will like to intervene again. You have to create a retinal detachment. You have to dislodge the PFCL bubble because it is stuck there. You can't just create a retinotomy on the fovea or near the macula. You have to create a retinal detachment and you have to absorb it, or there is one more technique, as Dr. Ajay said, you flush it and remove it. But PFCL bubbles, they usually come out once you create a retinal detachment. You just have to aspirate it.
Can I answer that question? Wonderful presentation, Bhuvan. So I have had two situations like this. One is the bubble of PFCL is subfoveal. Second is the bubble is extrafoveal. If it is extrafoveal and not compromising vision, I would see that it is not moving around. Some people have even described a little laser around the bubble so that it stays there put and doesn't move around. And then the vision remains. If it is subfoveal, a small bubble, and is likely to compromise vision, what I did in a case, I'm not saying it was right, it worked. I took a 40 gauge cannula. It's an expensive way of handling it. Identified the bubble on the OCT. Ideally, it should be done with an intraop OCT. I don't have an intraop OCT. Went in through the fovea with a 40 gauge thing, one shot inside, removed it, done. Obviously created a small foveal break, but the patient's vision improved. So that is one way of doing it. I'm not recommending it, but it worked for me.
I think
best preventive way to prevent this is not to inject PFCS.
yeah, that is very important.
Near around the posterior pole, the chances of it going back are more. Only if you are suspecting that you may land with the break a little beyond, then inject PFCL. PFCL does reduce that, stops that bleeding. But prior to that, you just raise the pressure.
Yeah, that I've mentioned. That is the last.
And when you inject PFCL, inject it as a single bubble. So so when you inject, don't inject from a distance. Get within the bubble, allow it to enlarge, because if you have multiple bubbles, then it's tough. So that's what.
And just one more point. Once you have displaced the bubble, you can also inject PFCL over the retina to displace the fluid from the center of the macula. So over it, so that the PFCL bubble is pushed away from it, and then you can aspirate it from a retinotomy created.
Yeah, I just wanted to move away from perfluorocarbons just a bit, just to emphasize the points that you made. Now we are all carried away by the capabilities of the newer machines and our own surgical skills, and we set out to achieve what may be anatomic marvels, but functional disasters. So it's always good to combine technique with temperament and not go after every single fibrovascular proliferation, as you rightly said, an extramacular fibrovascular proliferation or a benign proliferation over the disc. You want it to be removed, and then you have a massive bleed. So it's better to know when to stop.
It's like a creeper. Sometimes you have to let the root be there, remove the creeper.
Sir, I have one doubt in the CKD patients, it just doesn't stop bleeding, it just doesn't clot at all, who are on dialysis and, these kind of patients. So, do you advise them dialysis the day before the surgery, or does that make a difference?
Personally, I don't think having a dialysis before surgery, I don't have any experience. I don't think so it will make a difference, but probably if anybody.
So we had a patient who I operated 2 times, and then I went into more into greater details. This is many years back before we started understanding this. So whenever I have to operate these patients, I convert them to a heparin-free dialysis. Second is, if many of these patients actually do better with the peritoneal dialysis rather than a dialysis on the normal. So a patient who was bleeding repeatedly, we had done all laser, everything, still he would come back with a small bleed. So we converted them to a peritoneal dialysis. It works well. If it is a dual drug, I stop it for 6 days. If it is aspirin, stop it for 4 days. If it is clopidogrel, stop it for 6 days. I think it is very important. Other thing which I think Dr. Mahesh has been doing is to use patient's own plasma for a thrombin, which can be used intraoperatively to make a clot, which is useful.
You were making a comment.
It's a bi-weekly dialysis. I ensure that my surgery is midway or immediately after the dialysis, so that the next dialysis is a little away from my surgery.
Absolutely.
Yeah.
That is important. The next dialysis should be a bit